Hello. Good day to all of you joining us from across the world today for this, our second webinar of the International Federation of Fertility Societies in collaboration with the International Society of Andrology. This webinar today is going to focus on male reproduction for the clinical assessment and the diagnosis. These webinars, a series of 6 of them, bring to you experts in the field of male infertility and, of course, the reproductive endocrinologists and the andrologists. The highlight is that each one webinar, if you attend, you will be given an individual certificate for the same, and all of these speakers are being invited to attend the IFFS World Congress at Tokyo in April 2025. Of course, if you want to view these webinars again, we do have on-demand viewing on the IFFS website. And we welcome you to join us for the subsequent webinars as well, the next one being on the 10th of December on the medical and surgical interventions in male infertility, followed by the one on 14th of January 2025 on special issues in male reproduction. So let's start today's webinar on male reproduction, clinical assessment, and diagnosis. We have with us our first speaker for the day, Dr. Cilla Crowns. She's an MD from Florence, Italy, and her PhD in human genetics is from France. She's a professor of endocrinology at the University of Florence and co-director of the Florence European Academy of Andrology Training Center. She is the author of more than 140 scientific papers. She has served as the president of the European Academy of Andrology from the year 2014 to 2018. And today, she will be speaking on the clinical spectrum of male reproduction disorders from azoospermia to normospermia. On to you, Dr. Cilla.
Thank you very much, Rishma, for this nice presentation, and good morning and good afternoon, everybody. So I'm going to talk about clinical spectrum of male reproduction disorders. And when we talk about male factor, actually we refer normally to those situations when the patient has an altered routine sperm parameter. It can be at the level of number, motility, morphology, or the combination of these 3 parameters, and we refer to it as oligoasteroteratozoospermia. Now, in a minority of cases of our male factor patients, we have a semen deposition disorder, which can be aspermia due to retrograde ejaculation, for instance, or coital disorders due to erectile dysfunction. We may also have patients who have apparently normal sperm parameters, so at the microscope we cannot see anything wrong, but they may have altered DNA integrity or altered DNA methylation or sperm function. The most severe form of male infertility is azoospermia, and this is just a symptom. We don't have spermatozoa in the ejaculate, but at the testicular level, the histology can be very different. It can be absolutely normal, the spermatogenesis, in case of obstructive azoospermia, or it can be very different in case of non-obstructive, where we can have Sertoli cell only picture or spermatogenic maturation arrest at different level of maturation, or hypospermatogenesis with very few tubules with normal sperm production. And obviously, depending on the histology, we may have virtually zero probability to find spermatozoa in these conditions, but it can be virtually 100% in obstructive cases or 50% on average for hypospermatogenesis. Now, the origin can be at the central level, FSH-LH can be low, but in the large majority of cases, we have a primary testicular problem. So the hormones are there, and also the ductus are integral, but there is a problem here. In about 10% of cases, we can have a post-testicular cause, which can be obstruction or subocclusion at the proximal or distal level of the urogenital tract. For each of these categories, etiological categories, we already know that there are genetic factors which we can test for, and we have also acquired forms of these causes. So let's start with the first one, which is the congenital hypogonadotropic hypogonadism. It can be syndromic or isolated with normosmia. And nowadays we can test with the next generation sequencing for about 35 genes. We can find mutation in one of these or two or three of these. In Florence, we have about 40% of diagnostic yield. Now, these patients are normally coming for delayed puberty, and then we see them at the clinic because they would like to have a stimulation with hormones for obtaining spermatogenesis. In the acquired conditions, normally these conditions develop after puberty or in adulthood, and here we have malignancies in the brain or pituitary adenomas or infiltrative diseases. So this was the pre-testicular central forms, where the diagnosis is made by measuring FSH-LH, so FSH-LH are low, the patient is azoospermia, but look at the difference of the phenotype. Here we have a congenital hypo before any treatment, and here we have this man who has very similar biochemical analysis, but he has a completely different phenotype, and that is due to anabolic steroid abuse. So moving to the post-testicular cases, so we can have here, I would like to emphasize this situation, which is called congenital absence of the vas deferens. It can occur with normal renal anatomy or with unilateral renal agenesis. Now, when it is with normal renal anatomy, we know that the CFTR gene is involved in more than 90% of cases, and the CFTR gene is the gene for cystic fibrosis. But depending on the mutations, it can only give this reproductive phenotype. If the two mutations are not found, we can search for this X chromosome linked gene as well. Now, more and more often we see patients with cystic fibrosis, so they are, by definition, they have this, the reproductive phenotype congenital bilateral absence of vas deferens. These are due to two severe CFTR mutations, but in this case, due to the medications and to the general health problems, usually we have a combination of obstructive and testicular damage. Now, apart from quantitative impairment, we can have only qualitative impairment. For instance, the morphology of the spermatozoa can have a so-called monomorphic teratozoospermia. So that means that mainly we have only globosospermic spermatozoa, and that can be due mainly to the DPY19L2 gene mutation. And it's important to know and make the diagnosis, because in these cases there would be a need for artificial oocyte activation. Another monomorphic teratozoospermia is the macrozoospermia, is macrocephaly, and these spermatozoa are usually tetraploid, so it will be impossible to obtain normal embryos, and this is due to aurora kinase C mutations. Another qualitative problem can be at the level of the motility. This is again rare recessive conditions. We can have primary ciliary dyskinesia or multiple morphological abnormalities of the sperm flagella. And in this condition, we know already there are at least 18 genes which we can test for them. And apart from affecting sperm motility and therefore natural pregnancy, some gene mutations, such as this gene, when it is mutated, it affects negatively embryo division. So it can be a problem not obtaining embryos in the context of in vitro fertilization. Now, as I said at the beginning, the most important and most frequent cause of male infertility is related to a primary testicular problem, and this can be genetic, non-genetic, presumed genetic. And concerning the genetic factors, actually we know that the highest frequency we can find of karyotype abnormalities or AZF Y chromosome deletions in the azoospermic group. In oligozoospermic patients, this percentage is lower, and usually the karyotype abnormalities are structural abnormalities rather than numerical. Now, if we compare the testis phenotypes, for instance, in cases of sex chromosome anomalies, here we have an extra X chromosome, the Klinefelter syndrome, and the testis histology is characterized by high alinization, and very few tubules may still retain some spermatogenesis, and in these cases we can actually try to do TESE. On the contrary, if we have a TEX11 gene mutation, this is on the X chromosome, it is an essential gene for meiosis. Therefore, if there is a loss of function mutation, we will have a maturation arrest, and there would be no TESA success. The Y chromosome deletions, they may have very different testis phenotypes, and we know that there is this genotype-phenotype correlation depending which region is removed. So the complete A and B region deletions are associated with very severe testis histology, and in these cases, actually, TESA is virtually has zero chance. On the contrary, the most frequent type of deletion, the AZF-C region deletions, are compatible with either oligozoospermia or azoospermia with a TESA positivity in about 50% of cases. Now, these are more or less the most important genetic factors which we know. There are also non-genetic acquired conditions which may cause either oligozoospermia or azoospermia. It can be testicular torsion or orchitis or malignancies or cytotoxic chemotherapies. And therefore, there are a number of causes which we can detect by doing by taking medical history or examination or physical examination. But what is really disappointing that after a whole and a standard diagnostic workup, in about 50% of cases, we cannot actually define the etiology, and we refer to these cases like idiopathic oligozoospermia or azoospermia. And in this paper, we wrote that it's probably behind these conditions, there is some presumed genetic factors, a hidden genetic factor, which we cannot see at the moment. And why we expect that is because we know that the testes express more than 2,000 genes, and it is expected that more than 2,000 genes are important for the spermatogenesis, and almost 500 of them are exclusively expressed in the testes. So if there is a mutation in one of these genes, we could expect a reproductive phenotype. And if the mutations in other genes, which are eventually expressed also in other tissues, actually we can expect also some other health issues, not only reproductive phenotype. So how we can study with these 2,000 or more than 2,000 genes? Nowadays, next generation sequencing allows to study the whole exome, basically, and then we can filter from this data set those which are of our interest. Like in this study, we extracted 145 gene related variants, so those genes which are those variants which were mapping into these genes, and by selecting only likely pathogenic and pathogenic variants, we found in 12% of these patients a genetic diagnosis. So they are not anymore considered idiopathic, but we found the genetic cause. What is interesting is that apart from defining the genetic etiology for non-obstructive azoospermia, some of these genes are also important for the maintenance of genome integrity. And as you probably know, DNA repair gene defects are relevant because during mitosis or meiosis, they can cause problems, as well as they are important predisposition factors for tumorigenesis. Another interesting finding in this study was that some of these genes not only cause azoospermia, but also premature ovarian insufficiency. So that means that depending on the mutated gene which we can find, we can advise long-term follow-up to the patients, and the gene mutation can have a relevance for the siblings of both sexes, not only for the brother, but also for the sister, and for the offsprings, not only for the son, but also for the daughter. Now, my last part is very quickly about what can go wrong when we have a normal zoospermia at the microscope, but it's still expected that there is a male factor. So, for instance, rarely mutations can occur in genes which are important for sperm-egg interaction. And if these genes are mutated, we will not see necessarily any alterations of the routine sperm parameters. And also, it can happen that these kind of environmental and lifestyle factors and advanced paternal age, for instance, may alter DNA integrity, like DNA may cause DNA fragmentation or alteration of the sperm DNA methylation, not necessarily leading to altered sperm parameters, routine sperm parameters. But these environmental factors have been also claimed that they are probably the responsible for the fact that in the last 50 years there was a significant decrease of the average sperm count in worldwide in the general male population. And that is an important point because in 2018, we were around 49 million spermatozoa per ml, and we know that that is already starting to be correlated, as you can see here, with the probability of pregnancy. So in conclusion, I would say that male factor affects about 8% of the male general population. It is certainly a multifactorial condition, and the semen and testis phenotypes are heterogeneous, as well as the etiological factors. And idiopathic oligoazoospermia are likely to be due to hidden genetic factors. Nowadays, with the next generation sequencing, we can improve our diagnostic capacities. And of course, we have to be careful about lifestyle factors, environmental factors. Actually, we can actuate prevention and increase awareness about these factors which can alter spermatogenesis at the epigenetic or at the DNA level. So thank you very much for your attention.
Thank you. Thank you so much, Dr. Chilla. We have questions coming up, but we'll take questions at the end of the speakers. And we now have Dr. Peter Liu, who will be speaking to us. He's a professor of medicine at the David Geffen School of Medicine, UCLA. He has done his MBBS and PhD from the University of Sydney, Australia. He's published more than 100 original articles in leading scientific publications, and he is the president of the International Society of Andrology. So we are lucky today to have such experts with us, and he will be speaking on the optimal assessment of the male. Over to you, Dr. Peter. Dr. Peter, you're muted. You're muted. We can see your slides very well.
Okay, can you hear me now?
Yes.
Okay, so it's a real honor to be here, and I wanted to thank the organisers for inviting me. Okay, I have no disclosures. So the optimal evaluation of male infertility requires a thorough history and examination, appropriate investigations, semen analysis and endocrine workup, and consideration of genetic screening and counseling. This is in order to identify treatable conditions, including gonadotrophin deficiency, obstruction of the urogenital tract, and coital disorders. Optimal evaluation is required to determine candidates for corrective surgery or assisted reproduction, and to assess for associated comorbidities, because infertility is a sentinel event. So, for example, discovering testosterone deficiency, which might require testosterone replacement therapy, or discovering and treating metabolic diseases to prevent future cardiovascular events. The thorough evaluation is required because the symptoms of male hypogonadism are non-specific. These symptoms include diminished libido, erectile dysfunction, diminished motivation, decreased muscle strength, reduced endurance, sleeping after lunch or dinner, less enjoyment of life, difficulty concentrating, less beard growth, and impaired fertility. The components of the andrological history includes an assessment of disorders of sexual development, such as evidence of a history of penile hypospadias or genital ambiguity at birth, which might suggest a genetic or hormonal abnormality, inguinal hernia or cryptorganism in infancy or early childhood, which might suggest testicular cancer. The age of puberty and its progression is also very important. The age of shaving, voice deepening, and the growth trajectory might provide indications for the presence of hypogonadism. The age of initiating sexual activity is also important. The sexual history is also part of the standard andrological history. And in particular, a history of erectile dysfunction is important to elicit because it's a sentinel event that indicates the possibility of cardiovascular disease. In fact, cardiovascular diseases can occur 10 years after the onset of erectile dysfunction. Abnormal penile curvature might be obtained historically, and this may be directly treatable. Low libido should be considered as a potential symptom of hypogonadism. Orgasmic disorders, including post-ejaculation cloudy urine, may suggest retrograde ejaculation, which again can be directly treatable. The use of lubricants, the timing of and frequency of coitus, and the use of contraception are also important parts of the sexual history. It's also important to elicit a history of reproductive or sexual diseases, in particular sexually transmitted diseases, mumps orchitis or epididymo-orchitis, prostatitis or urethritis, all of which could cause obstructive azoospermia. The general history is also important to elicit, particularly a history of cancer. Prior chemotherapy, especially using alkylating agents, can result in infertility. And in fact, there's a higher frequency of sperm aneuploidy 12 to 18 months after completion of chemotherapy. A history of radiotherapy to the scrotum or pelvis could indicate a cause for primary testicular failure. Similarly, it's important to elicit a history of systemic disorders, particularly metabolic disorders such as obesity and type 2 diabetes, especially if it causes neuropathy. And this is a sentinel opportunity to intervene in cardiometabolic disorders to prevent future cardiovascular events such as heart attack and stroke. Hypothalamic pituitary disorders such as tumors and infiltrative diseases of the hypothalamic pituitary unit, hemochromatosis, hypoprolactinemia, and hypogonadotrophic hypogonadism, including Kalman's syndrome, should be elicited. Other endocrine disorders, including hypo and hyperthyroidism and hypercortisolemia from any cause, all of which can cause impaired spermatogenesis. Adrenal rest tumors from severe untreated congenital adrenal hyperplasia is also another an endocrine cause of infertility. And in fact, approximately 1 in 4 of all infertile men have some form of endocrinopathy, which may require treatment in its own right. In fact, infection or any significant febrile illness can temporarily reduce sperm output, and other systemic disorders such as hemochromatosis, renal failure, liver cirrhosis, or sickle cell disease can also reduce sperm output. The drug history is important to elicit for drugs such as corticosteroids, 5-alpha reductase inhibitors, and sulfasalazine, all of which can impair spermatogenesis. Certain abused drugs such as opiates and androgens can also cause secondary hypogonadism by suppression of the hypothalamic pituitary axis. Recreational drugs such as tobacco, alcohol, and marijuana can also directly impair testicular production of sperm. And there are also other drugs that can affect ejaculation, in particular serotonin reuptake inhibitors, which can cause anorgasmia, or alpha adrenergic blockers, which can cause retrograde ejaculation. The surgical history is also important to elicit, in particular a history of scrotal trauma or testicular torsion. Any history of pelvic, retroperitoneal, or genital surgery should be elicited. In particular, hernia repair with mesh repairs can cause secondary inflammation of the vas deferentia, which can lead to obstruction of the genitourinary tract. Transurethral prostatectomy and retroperitoneal lymph node dissection can cause retrograde ejaculation, another cause of male infertility. And a genetic and family history is important to elicit, in particular, history of behavioral or educational problems that may suggest Klinefelter syndrome, and other conditions that might impair fertility, including cystic fibrosis, hemochromatosis, sickle cell disease, and thalassemia, all of which may be directly treatable. The physical examination of the genital appearance, eliciting a unicoidal proportions, masculine appearance, and the body mass index, gynecomastia versus lipomastia, and nipple discharge could suggest hyperprolactinemia and any congenital abnormalities. A general examination looking for endocrinopathies, which may require examination of the thyroid or of visual fields. Hepatosplenomegaly might suggest, for example, hemochromatosis. The andrological examination consists of assessment of Tanner stage, the penis, the presence of hypospadias plaques, which could suggest Peyronie's disease, skin lesions or urethral discharge for sexually transmitted diseases. The scrotal examination involves measurement of testis size by Prader orchinometer, of the epididymis, feeling for induration or tenderness, for the presence of the vas deferens, and for the presence of varicocele, which can be detected by having the patient stand or through the Valsalva maneuver. A digital rectal exam assessing prostate size and consistency, anal sphincter tone, and perinatal sensation might be required if appropriate. We've already heard about the investigations, which includes the semen analysis, which is the cornerstone of male evaluation, the endocrine evaluation, which involves the measurement of the pituitary gonadotrophins, testosterone and SHBG, free testosterone in some cases, estradiol if there's hypogonadism, prolactin and iron saturation if there's evidence of secondary hypogonadism, and as we've heard before, genetic testing in select cases. Now, the clinical syndrome of hypogonadism needs to be confirmed biochemically, and a recent guidelines published by the Society of Endocrinology in conjunction with the Association of Clinical Biochemistry and Laboratory Medicine concluded that blood should be drawn in the morning, fasted, and after a good night's sleep. testosterone levels are usually highest in the morning and lowest in the afternoon. However, this pattern does not occur in night shift workers because the diurnal pattern is driven primarily by sleeping patterns, not by circadian factors. And in fact, 15 to 20% of all workers are night shift workers. Night shift workers often have symptoms that are highly suggestive of hypogonadism. They can also have impaired fertility and will often attend an infertility clinic. So night shift workers often have symptoms that will trigger an assessment for male hypogonadism. And those that are suspected to have hypogonadism require a specialist evaluation because the biochemical interpretation of the hormone analysis is complicated. I won't go through the genetic testing, which has already been well described by the first speaker. And in the last few minutes, I wanted to come back to the optimal evaluation of male fertility, and in particular, the importance of identifying treatable conditions, such as, for example, gonadotrophin deficiency. So gonadotrophin deficiency has hypothalamic as well as pituitary causes. The hypothalamic causes are IHH as well as Kalman syndrome. The pituitary causes are of its pituitary tumor or of its treatments, as well as pituitary aplasia. And either hypothalamic or pituitary causes can be treated with gonadotrophin therapy, but hypothalamic causes can also, in theory, be treated with pulsatile GnRH pump therapy, although pulsatile GnRH is not available anywhere in the world as far as I'm aware. Now, even though gonadotrophin deficiency is incredibly rare and represents less than 1% of all cases of male factor infertility, it's important because it's one of the few treatable causes of male infertility. And in fact, there's a number of predictors of its treatment response, some of which we've highlighted before in the assessment of male infertility. And these include factors that are related to the male and the partner, including the male's age and the partner's age, the diagnosis, whether there's multiple hormone deficiencies from, for example, pituitary disorders, the testis volume, a history of cryptorchidism, and the history of puberty. And other predictors of the treatment response to gonadotrophin deficiency include the number of cycles of therapy and whether or not androgens have been used in the past, particularly at the time of puberty. And here I'm showing you data from on sperm induction in a large retrospective cohort of 75 men who underwent 116 cycles of therapy, of gonadotrophin therapy, which consisted of 6 months of HCG alone, followed by HCG plus FSH in Australia. And what I'm showing you here are the Kaplan-Meier curves, showing the time to first appearance of sperm, to a sperm concentration of at least 5 million per mil, to a sperm concentration of 20 million per mil, as well as to conception. And what you can see is that it takes a long time to have first sperm. On average, it takes 7 months, and can take, on average, 28 months or 2 years for the first baby to be conceived. And so even though this therapy is highly effective, it takes a long time, and it's important to be persistent. And in this analysis, we also looked at the multivariate predictors of response. So looking simultaneously to see what are the independent factors that can result in the first appearance of sperm, a sperm count of more than 5 million, a sperm count of more than 20 million, or conception. And you can see that the testis volume is a highly significant predictor, as well as the presence of more than one cycle of gonadotrophin therapy. The main detrimental predictor for response is prior androgen use, which resulted in a much slower occurrence of sperm parameters. And in fact, if you look at pregnancy outcome, conception per se, it predicted slower induction of pregnancy. So in summary, the predictors of faster response was multiple cycles of therapy, no previous androgen use, and increasing testis volume. But the fact that androgen use was detrimental raised the question about whether or not gonadotrophin deficient boys, whether they should be treated with gonadotrophins, not androgens, to induce puberty. And in fact, that concern has not been confirmed on subsequent studies looking at the impact of prior testosterone therapy on spermatogenesis. And in this study on the left, which was a multi-center prospective study of gonadotrophin therapy to induce puberty in hypogonadotrophic males, there was no difference in boys that were treated with testosterone before versus those that were treated with not treated with testosterone. But if you look at the data, the p-value was 0.07, showing a trend for slower sperm concentrations in men that were treated with testosterone before. And in a meta-analytical study, there was no indication that the prevalence of subjects with previous TRT influenced spermatogenesis onset. So in summary, male factors are responsible for 1/3 and contributors to half of all cases of infertility. Despite these therapies tend to be female-directed, more research is needed to address this imbalance. Male hypogonadism is a syndrome due to dysregulation of the HPT axis that requires biochemical conformation. The optimal assessment of male infertility aims to discover rare but treatable causes of male infertility and to unveil testosterone deficiency and cardiometabolic disorders that may need to be treated, as well as genetic mutations. And I'd finally like to acknowledge the people that did the work, and particularly the trainees in my lab. Thank you.
Thank you so much, Dr. Peter, for this wonderful talk. And we will be taking questions at the end of the talks. So kindly put your questions in the chat below. And now I have the pleasure of inviting the last speaker of this webinar, Dr. Daniel Santi. Dr. Daniel is an assistant professor at the University Hospital of Modena, Italy. He has done his PhD in clinical and experimental medicine. He works at the Unit of Endocrinology at the Department of Biomedical, Metabolic, and Neural Sciences, University of Modena, Italy. And today, he's going to be speaking to us on the Aphrodite classification. On to you, Dr. Daniel.
Thank you. Thank you for the presentation. So my task deals with the introduction to the Aphrodite classification. So Professor Liu already explained us the sperm induction in gonadotropin deficiency. So we are already into the topic. I just want to give a brief step back to give an introduction of the topic, since you know that if we have to consider the male partner of an infertile couple, we have to reach a diagnosis to recognize the causes of the male infertility where possible. And you know that the classification is still pre-testicular, testicular, and post-testicular causes. But this definition is still less or not so useful from a clinical point of view, because in the same category we have different causes, different patients, and different treatment that we can choose for the patient. This is just suggested the new classification of men with infertility, in which we try to give some different groups considering the etiology, because you know that in male infertility, as well as in other clinical disease, we could have different treatments, different strategies. And considering male infertility, we could talk about an etiological treatment when we have to resolve the cause of the infertility. Is the example of an infection of the genital tract. The treatment in this condition is the treatment for the infection and not in other way. And so the management of the cause, to remove the cause. Or we can act with an oriented management to try to act on the risk factors, such as obesity, for example. A goal-oriented management, when we try to overcome the problem, is the case of duct obstruction due to genetical causes. For example, we have to search sperm within the testes. But we have also an empirical management. So an empirical stimulation of the testes when a cause is not detectable, generally trying to improve the sperm production. And this is the case of the hormonal stimulation in the management of male infertility. This is the setting in which the Aphrodite criteria should be included or should enter. You know that, for example, on the counterpart, so on the female part of the infertile couple, the ovarian stimulation is still an empirical for many aspects, is still an empirical treatment. And gynecologists apply different approaches, different therapeutic scheme and dosages and so on. And they try to select the patient, select the women using different tools to better personalize the treatment. One of these is, for example, the Poseidon criteria. That is a classification created considering parameters that are collected during the diagnostic workup, so the age or the markers of ovarian reserve, such as AMH, AFC, and they create these 4 different groups of different potential response to ovarian stimulation, and they use these groups to personalize the treatment, to select the best hormonal stimulation for each woman. And so the Aphrodite criteria is the same on the male counterpart. This is the advisory board that we created 3 years ago to create this criteria. The board is formed by gynecologists, urologists, and endocrinologists. And we suggested this Aphrodite criteria. Obviously, the name is the female counterpart of Poseidon. And the aim of this classification, the aims of this classification could be summarized as first, it is an attempt to try to classify the men with male infertility that could benefit for an hormonal stimulation. And we try to create these groups starting with the clinical examination to recognize the best hormonal treatment that could be suggested. And second, this classification is an attempt to try to standardize the approach to the male infertility. So to talk the same language, so to highlight a potential lacking point in the evaluation of male infertility, both from a diagnostic and also from a therapeutic point of view. The classification considers these 3 points, so semen analysis, that is defined normal or altered according to the 5th percentile of the manual of the WHO. The FSH serum levels, defined as normal or elevated, and the threshold selected during the advisory board was to consider the upper limit of the reference range of each laboratory, since a clear cutoff is not well demonstrated. And the testosterone serum level, so total testosterone serum levels, that is defined as normal or reduced. And for this, you know that there are many guidelines and position statements to suggested the best threshold for testosterone, we selected this 3.5 nanogram per ml, so 12 nanomole per liter. That is the most widely accepted threshold. With this 3 point, we created the 5 different groups. The first is the most simple, I think. So the classical hypo, so the classical hypogonadotropic hypogonadism. So the man with a reduced, unaltered semen analysis, a reduced FSH, a reduced testosterone serum levels. And these are the patients that benefit with a replacement therapy. So a therapy that tries to replace the physiological pituitary stimulation on the testes. You know that different approaches are available. Already, Professor, you show us the result. This is just the demonstration of what we know in clinical practice, because these men significantly improve sperm production after a replacement therapy. I think that this, by the Florence group in 2014, is still the most comprehensive meta-analysis on the topic, enrolling including more than 60 trials involving hypo men treated to evaluate sperm production, and showing that if we use a replacement therapy, we have an increase in sperm production that is significantly also from a statistical point of view. This is what we know already from the clinical practice. The second group is the true idiopathic male infertility. So the men that show altered semen analysis, normal FSH, normal testosterone serum levels. And these are the men that could benefit from an hormonal stimulation with FSH. This, is a treatment that is allowed only in few countries worldwide. Italy is one of these. But it is also evaluated in the literature. We have many trials. This is a meta-analysis that we published some years ago that tried to comprehensively evaluate the efficacy of FSH, showing that if we use FSH for the male partner when an idiopathic infertility is detected, we obtain a significant increase in sperm production, so sperm concentration and sperm quality in terms of motility, and a significant increase in pregnancy rate. But if we calculate how many patients, how many men we have to treat to obtain one pregnancy, so the number need to treat, the number is quite high, because we have to treat from 10 to 18 men to obtain just one pregnancy. This probably means that we have to rethink about this treatment, because in Italy, where FSH is allowed, but also in trials available in the literature, in most of these trials, the scheme used is the same used for the treatment of classical hypo. So the same replacement therapy is used also in idiopathic infertility. And so probably we have to rethink about this aim, and we have to shift our vision, talking about probably a stimulatory treatment rather than just a replacement therapy, because these are not patients with lacking stimulation from the pituitary to the testis. The third group of Aphrodite criteria is men showing reduced altered semen analysis, normal FSH, but reduced testosterone. These men are probably men with a functional hypogonadotropic hypogonadism. These men are probably the men that could benefit from an hormonal stimulation, such as in the group 1, so a replacement therapy. Probably this subgroup is the group of men that in the meta-analysis evaluating studies using FSH in idiopathic infertility, this probably is the subgroup that really benefit from the current scheme of FSH stimulation. And considering the epidemiology, we expect that this group is not so small. This study, we published this study this year is a case control study comparing more than 200 men with idiopathic infertility with more than 200 men that perform semen analysis and hormonal evaluation just for screening purpose. And as you could see in the figure, we have in blue the idiopathic infertility. The testosterone serum levels is shift on the left comparing to the control group in red. And in idiopathic infertility, we have a mean 23% of men showing reduced testosterone, suggesting that also testosterone could be a useful marker to classify or to subclassify men with idiopathic infertility. The fourth group is the group with functional hypergonadotropic hypogonadism, so men with altered semen analysis, normal testosterone, but elevated FSH, and these are clinically the worst scenario, since in these men generally are azoospermic, and generally these are the men that should be treated with sperm extraction, testicular sperm extraction, but some suggestions, but are still suggestions in the literature, suggest that we can probably treat these men with the ACG, or why not with FSH prior to sperm extraction to increase the sperm retrieval rate. But so far there are still some suggestion on that. And finally, the fifth group is the group of typical unexplained infertility. So men that are normal parameter but infertility. So in conclusion, Aphrodite criteria is just a way to try to classify this patient that could benefit with the hormonal stimulation. And probably we are in this way highlighting the lacking point that we have still in the literature and the need to increase the research in this field. So thank you.
Thank you so much for a very, very interesting talk, Dr. Daniel. And now we will run through some of the questions asked by our viewers. So the first question is for Dr. Chiller. And just give me a minute and we'll go through this. Okay. Yes, this question is from Dr. Roman Litvinenko. I hope I pronounced your name well. And the question is, what are the restrictions on the possibility of conceiving a child for patients with Klinefelter syndrome? So can we help a patient with this syndrome over the age of 14 to achieve fertility through ART? So Klinefelters, how do we manage?
Okay, thank you. Thank you for the question. Yeah, Klinefelter syndrome patients, actually, as I said, they may have ongoing spermatogenesis in some tubules. The problem is that obviously the timing of the TESA, so the testicular biopsy, it has been described, especially by the German group from Sabine Clichy group, but also others, that it should be performed below the age of 32. So that is the optimal timing when you can do the testis biopsy. And there is more and more consensus that it doesn't matter. You don't need to do it at the age of 15 or 16. It will not increase the chance. So it is not urgent to do it right after the puberty. So that's what is important, that you do the TESA and micro TESA possibly before the age of 32. And obviously there are factors which can predict a higher or lower chance. It depends also on the testosterone level, on the testis size, but you don't have an absolute predictor. This patient can go, this patient cannot go. So you don't have predictor factors. You have to, only predictor is the age. So you can send your patients, I don't know how old is this patient, but I mean, you can send for the TESA.
Thank you. Thank you, Dr. Chiller. Then our next question is from Ofior Yama, and this is directed to Dr. Peter. How do you take a detailed andrological history when the wife is present? Because the man may not want to disclose everything in front of his wife. he may be uncomfortable. So it's a very practical question. How do you tackle this situation?
So I think it's important that the couple being assessed together as well as separately. And I think that particularly in certain countries where there's endocrinologists that are heavily involved in the management of couple infertility, often the endocrinologist/andrologist will separately assess the man, and the OBGYN will separately assess the woman, and then the IVF doctor will assess them together. So I think it's a very important point, and you're absolutely right. You need to have separate assessments.
Right. So it's a very, like I said, a very practical point, and we have to be very sensitive to that, not only for the man, but for the woman, interviewing them separately as well. Great. Our next question is, I think, directed again to Dr. Peter from Olidair Adeyemi. And this is a case, interesting case that has been presented. Is a 41-year-old man with testicular microlithiasis and bilateral scrotal varicocele. The sperm count is adequate, cell morphology is 50%, but the motility is 15%. What are the treatment options? And this person has a hormonal profile which is not remarkable and has already undergone a bilateral varicocelectomy subsequently. So how do we manage this person?
I'm happy to start, but actually Danielle's talk was actually very much addressed to this. So according to the Aphrodite criteria, he would be one option might be gonadotropin therapy. So maybe Danielle might want to speak more about this.
Dr. Daniel, would you like to take that?
Yeah. I already explained that the gonadotropin could be useful in this treatment. I think that it should be a good option for that. So, and about the regimen is quite more complex since, as I already explained, there is no standard approach, or at least a wide demonstrated, and so it is not clear. We need still to examine which should be the best approaches for this.
Right.
If I may, so probably here the sperm number is normal, as I understood. So the only problem is about the motility. So certainly in these cases, it should be also useful to know whether there are other signs, for instance, of inflammation or infection, because if it is only the motility, then it should be, to make some more exams focusing on the motility, at least for this. And of course, we need to have at least 2 sperm examinations before then we make any diagnosis. So at least twice it needs to be tested.
Yeah, if I can, really, when gonadotropin is started, the diagnostic workup should be ended, and so we have to exclude any other reason for the alteration, potential causes that could be solved. So this is obviously.
Thank you. I think we have time only for one last question from Dr. Dhirendra Pal Singh. He's an embryologist, and he's saying that patients are often subjected to X-rays, and if it's a pelvic region X-ray, does this affect the quality of the gametes or the genetic materials, and what are the possible changes in his maybe sperm count, etc.? So anybody can take that, damage of X-rays to the male.
If I may start, I mean, if my understanding is the severe long-term pain, swelling, it's more than X-ray, it should be an ultrasound examination. So that would not cause any problem. So I would go for ultrasound in these cases. And if somebody get one X-ray examination, is obviously not so, it would not cause any major DNA damage. If it is normally, as I said, for these kind of symptoms, we would not go for X-ray. So I think that it could be resolved, the diagnostic question with ultrasound.
So use much more of ultrasound wherever possible,
Yeah.
rather than X-rays. And I guess a diagnostic X-ray, single one, is not going to be very harmful, but you know, a lot of radiation obviously will. So I think we are running a little bit out of time, but I definitely have the you know, the ability to make sure that all of you can review these publications very well. You can go on to our website. And I would like to end this webinar with some very important messages for you. We have the IFFS World Congress in 2025 in Tokyo. As the treasurer of IFFS, and on behalf of our president, Dr. Edgar Macano, invite all of you to attend. We already have more than 1,000 abstracts which have come in, a lot of interest being generated. So please go ahead, you can scan this QR code and register for this Congress at Tokyo, 26 to 29 April 2025. Look forward to seeing all of you there. Very, very focused Congress with the best speakers from all over the world. And now I'd like to invite Dr. Peter to give you a little bit of information on his upcoming conference.
The International Society of Andrology, in conjunction with the American Society of Andrology, which is celebrating its 50th scientific session, would like to invite all the attendees to come to Washington, D.C. For our Congress, which will be held in March 29 to April 1. Dr. Cruz is actually the one of the co-chairs of the program organizing committee, and they've assembled a wonderful program.
Thank you. Thank you so much for that. So all of you who are interested in andrology, you know where to go. So thank you so much, all of you, for joining us. It's really been a pleasure. And thank you to our outstanding speakers for being here and for coming in live and answering all the questions. We look forward to our next webinar. This is the second of the series of 6. So please do check our IFFS website, and we have a lot more interesting programs for you. This is Dr. Rishma Pai, IFFS Treasurer, signing off with a great big thank you to all of you. Thank you so much.
Thank you.
Thank you.